bring it in sometime.
Carter,
But thank you all for coming back after lunch, and I'm here to introduce Robert Furberg. So Robert is one of the most accomplished and innovative people working in digital health today, I think, and he's worked in this field for many decades. And it's rare to find someone with both his level of technical expertise and the health knowledge. The sort of these polysyllabic health words that just roll off the top of his tongue in the middle of the room. And he's worked, his history of working on really compelling projects too, as you'll see today. He's also been a great friend of the Health Sciences Library and of CHIP. And he helped us to write our initial grant for our digital health work when we got our grant with Cadre. And also, he donated the first devices for our digital health device collection. So, in addition to that, he was also our inaugural speaker for our digital health talks at the Health Sciences Library. So, I'm very happy to introduce, from this chair, Robert Furberg.
All right, awesome. Thanks, Brian. Thank you. I'm blushing. So when I was asked to do this, I took one look at the title that involved the word frontiers, and my mind just immediately went to Star Trek. And then when I started thinking about digital health, it immediately went to this, which is referred to as the WTF Picard meme that's used, it's an internet trope to express annoyance. And this is really how I feel when I go to most digital health events, because I am an applied investigator of public health and clinical interventions. We're going to describe a few of those today. And normally, I find myself sort of increasingly outraged by the hype and the sort of the lack of grounding or real applicability of a lot of the innovations. I say that, and I now have to soften this assertion, because everything I've seen so far has been super impressive today, and I think the stuff that the preceding speakers have covered is super cool, and I love seeing it. And so, great job to HSL and Cadre and Brian and Co. For doing this. So, onward. I probably do need to acknowledge my handlers. I come from an independent nonprofit research institution called RTI. We were founded as the Research Triangle Institute back in 1958. We're observing our 60th anniversary this year, and I work in RTI's digital health and clinical informatics program. Back to the Picard slide. I went to the Consumer Electronics Showcase back in January, and I was presenting at an IEEE conference that's the day after it. And as a part of my registration as a speaker, they were like, hey, come out a day early and check out CES. And I thought, okay, cool. I've always wanted to go. As a nonprofit, my handlers will say, no, that conference is incredibly expensive. Travel is it's like a week. So I said, okay, there's one day that's easy to kind of, tack this on. Has anybody ever been? Okay, so let me spit out a couple of factoids that might blow your mind. 180,000 people attend this event. It is the single largest event in the conference town of Las Vegas each year. It is a major economic driver for the city. It is very so taxing of their infrastructure and available hotel rooms that at this stage, in the last few years, they've updated this. No other conference can be co-located in Vegas at the same time as CES. There are 2.75 million square feet of exhibit space. So if you want to put your head into a big box store like a Walmart or a Target, those tend to run around 200,000 square feet. So let's take 10 of those. If you like property, this is 8 acres. What I'm showing you is the one area that I went to that was in the lower sort of region of the Venetian Hotel. These are the 7,000 exhibitors of digital health and wearable technology solutions from CES this year. And you probably can't read any of this, and that's kind of the idea, right? How many of these are going to be even in business or viable or able to afford going to CES 2019? My professional opinion is very few. Most of these are going to fail, and fail, pretty miserably. So, kind of think about the market. A lot of people will usually throw around, projections of units shipped or, the total sort of the financial growth of the market. I think it's a lot easier for me to ground my thinking of the consumer wearable device market in the number of products that are available. So right now there are 427 different consumer wearable sensors on the market available from 266 different vendors. So it's everything from like the Muse, like mobile EEG thing that sends stuff to your smartphone, to sensors that you can stick in your feet to analyze your stride and gait, right? And everything in between. We're all, I think, probably pretty well oriented to these trends in our personal lives around fitness trackers and the use of smartwatches, but increasingly investigators, researchers, clinicians are taking note, and I'm almost kind of horrified to acknowledge that as of last Friday, there are 217 registered clinical trials that are being or have been conducted internationally that use Fitbit devices for primary data collection. They're using a wholly, just by definition, unregulated device as a research instrument. What's kind of interesting and sort of encouraging, we've certainly been able to contribute to this, is also in a similar time frame, looking only at Fitbit that commands the greatest market share. There are over 500 peer-reviewed publications available today, only on one of the 266 different vendors, which is kind of nuts. So when we think about wearable technologies, this is what probably comes to mind. This is what things generally look like, right? The majority of these products are wrist-worn. There's a real emphasis on physical activity, specifically movement, kind of quantifying that. There's been the next wave of wearable devices really went into tracking sleep. The next wave after that has really started to incorporate some biometric data collection, heart rate, and we're seeing kind of an expansion from there. If your aesthetic sensibilities don't lend themselves to ruggedized plastic, black, a little bit of glass, it's okay, because I think there are two major trends in terms of how things are shifting. One, the feature set of consumer wearable devices is ever expanding and becoming more and more complex and more interesting, as we'll see in a minute. The other is that the form factor is just by definition changing. And so we're going to touch on a few of those, and then I'm going to roll out this gimmick that maybe some of you might not be able to see well. If you would like to, depending on the amount of interference in here, I think we have too many. I think that I'm going to say though. Anyway, if you would like to watch my heart rate after this, we can do that. Okay. So what in the world do I mean about an ever-expanding feature set and changes in form factor? Let's start here. This is the Omron Heart Watch. They'd originally planned on going to market with this thing, calling it Project Zero. This is a wrist-worn biometric watch that uses a sensor modality referred to as arterial tonometry. It's been snatched from critical care and ICUs to capture continuous ambulatory blood pressure in people. This is undergoing the final stages of FDA review and approval as a clinical device intended to support the screening, diagnosis, and treatment of hypertensive patients. This watch is going to retail for $350, which is basically how much people are paying for Apple Watches these days. There's the explicit intent of integrating this kind of product in data collection in NIH's Precision Medicine Initiative, now kind of rebranded as All of Us. So this is just sort of like one example of the kind of ever-expanding sort of feature set. And so we're going to start seeing, I think, more and more devices. I'm going to show you some more in just a second here, getting increasingly granular and clinically relevant and reliable measures from people. Right here is the implant I'm going to get in my gastroc medius next month, and I'm super stoked. I already have RFID tags implanted in both my hands, and so this isn't really much of a leap. This is a Profusa implant that, in this current sort of manifestation, measures oxygen concentration in skeletal muscle. So it's a really simple sort of injection into a largish muscle group. And then a companion sort of Bluetooth application that can be used to stream this kind of thing. The potential is greater than, although you think of some people with peripheral vascular disease or other sort of problems with perfusion, you can start to kind of recognize that there could be greater than novelty value to this kind of thing at some point. So we talked about wearables. Welcome implantables. So I want to acknowledge changing form factor in the form of other ables, and with kind of an eye roll, because some of these names are just horrible and they don't really work. Implantable, fine. Wearable, fine. This is a hearable. One of the other interesting trends that we're seeing with sensor-based data collection is that the sensors are going to other products that people have a reason to use. So if you think of the smartwatch, it's telling me time, it's giving me notifications from my phone, but then it's also the PPG sensor that's capturing my continuous heart rate and may or may not identify runs of, ectopy or other anomalous things like atrial fibrillation. In the sector of sort of physical activity, a lot of people like to rock out when they exercise. Naturally, there are wireless earbuds and headphones. So this is just a natural extension of the physical activity kind of application of putting PPG sensors for tracking heart rate. So in our community, there's a company called Cell, headquartered in Raleigh. Some of you may be familiar with these guys. They develop the PPG sensor itself. They then sell to wearable technology manufacturers, and they integrate their stuff in them. What's really cool about Cell is that they then go out and they buy these products, they bring them back into their shop, and it's super cool and super impressive, the validity and reliability studies that they run. They've got like a whole gym in their offices, and there are constantly people in there like working out, which is just kind of fun to see. Hearables I think are also noteworthy because are the sort of the baby boomer kind of thing, the silver tsunami as some people will call it, and there's this the increasing sort of proportion of older adults in our population. Frequently end up with some sort of like hearing loss or hearing deficit later in life. About 18 months ago, the regulatory barrier to entry for generating and going to market with a hearing aid was greatly reduced. So I think as we start seeing this initial wave focused on physical activity, rocking out, getting your heart rate, we're going to start to see more and more sort of high-tech, easier to use hearing aids as well. Earlier this year, I started consulting for a company another able. This is a swallowable. These swallowable technologies are really sort of intended to support one of three functions. Delivering something within a system, capturing information on its sort of movement from one end to the other, or capturing data and sort of transmitting it out from the organism. So right now, these kinds of products are being assessed for drug delivery systems that know where in the gut they are, that can take up residence for a couple of weeks and sort of continue distributing their payload. Other sort of aspirational, there's some sort of diagnostic and imagery kind of applications that are also on the horizon. One of the ones that I find most compelling as a researcher having to sort of deal with the burden of getting people to do diet and sort of nutrition data collection is the capacity for these devices to capture just purely objective, zero burden, totally transparent data collection on macro, micronutrients in the gut. I think would be pretty cool. About 2 or 3 weeks ago at AAAS, the University of Tokyo unveiled their work in this sort of adhesive skin-based biometric. It's sort of like part biometric sensor and part display, integrated display. The adhesive is intended for wear a week at a time in people. And there's a lot of work that's happening around assessing different types of metabolites or bioanalytes in sweat. So this is another big sort of area that is emerging. There's still a lot of basic science that needs to get done. And these are not ready for any kind of market, sort of deployment at this point. But, looking at, sodium concentration in sweat, looking at hydration status, starting to look at correlates for serum glucose. There's a blood alcohol tracking sensor that is, supposed to be coming to market soon. All of these things exist as potentials for data collection in sweat. And it's really kind of exciting because in all of this, I look at this as radically different sort of types of sensors. They look different, they measure different things, but fundamentally in the research enterprise, it's just sensor data. And it's just sensor data that needs to get linked to a person, that might need to be linked to a different type of data, and then feed into an analytic process. And so when I kind of think about all of this, I get really excited in the fact that the methods that we develop today around retrieving, managing, analyzing, and curating sensor data really, by principle, aren't going to change that much. The sensors are going to change. We're not always going to call it a Fitbit. It's not always going to be ugly. It's going to measure more and more stuff. But eventually, we'll feed it into the same kind of process. This is illegible, but we are, before the end of the month, really wrapping up our work on the development of the first biomedical ontology for patient-generated health data. This describes, so if you're like an informatics enthusiast or you love data and data structures, this is our first pass at a breakdown of the typical variables that you can capture using a wearable device and how they kind of relate to one another and the overall model that they sort of fit into. This is made available on an open biomedical ontology repository, so other people are invited to take a look at it, rip it apart, add to it, and kind of build on it from there. So kind of bringing things back to reality, right? When we kind of look at the state of wearable technologies today and their use in public health interventions, I really kind of tend to think of three types of data. There's the sort of metadata that people are reporting on themselves at the time of configuring a device. It's stuff that's used to impute body mass index and basal metabolic rate. Separately of that, the next kind of thing that we get to are these really pretty, rudimentary measures of physical activity, how much people are moving, right? If we look, people are getting really enthusiastic about tracking sleep because there's thought to be a greater and greater impact on sleep quality and the development and manifestation of various cardiometabolic disorders. Really, the sleep analysis is the same old wrist-worn actigraphy that people have been doing sleep studies on for decades. It's just put in a more consumer-friendly package and a prettier application. Expanded data sets that we're seeing on the horizon include more and more granular heart rate data, suitable for heart rate variability analysis that we heard about earlier, which is awesome. More and more sort of intelligent processing and imputation of what people are doing, so looking at heart rate data and physical activity combined to try to get a sense of exactly what it is people are doing, how well they're recovering. Interbeat interval, and some more measures of respiratory function that are suitable for like make myself pass out, that are suitable for complex respiratory analysis. So at RTI, I am lucky enough to lead a portfolio of primarily internally sponsored, really high-risk projects around the application of these new technologies toward the development of these sort of legitimate methods for then implementing these technologies at scale in public health and clinical interventions. What's cool is that we're starting to see like legitimate external funding, which I'll kind of touch on here in just a minute. Our longtime friend and collaborator, Kelly Evenson from the School of Public Health, is one of many collaborators here at UNC, beyond HSL, who we've been working with. And in our time together, have published what stands as the only systematic review on the validity and reliability of consumer wearable devices for physical activity tracking. We also, just recently, a couple months ago, got in print the first comparison of Fitbit aggregated health indicators in comparison with the US sort of public health standard for these same measures from CDC called the Behavioral Risk Factor Surveillance System. And then we've got multiple publications on different methodological innovations on how to go out and get this data, how to treat it, how to manage it, and how to create discrete linkages with traditional data sets, including biospecimens. After working with the Robert Wood Johnson Foundation over the summer, again in collaboration, in this case with Cadre at Fay, the Robert Wood Johnson Foundation released sort of the primer on work that we have in progress right now to develop the first sort of like standard for evaluating the validity of a consumer wearable device. So how do you sort of make sure that this thing is measuring what you want it to measure, and what is the measurement error that's associated with using these. A couple of quick studies and descriptions of quick studies that we're doing right now in the time that remains. So right now we're running a consumer wearable ancillary study with a large and a prospective longitudinal cohort over at the Carolina Population Center called Ad Health. This is a two-step process. In step one, we've deployed a survey and are in the process of data collection right now. To deploy a survey, we've developed 9 new survey questions that are going out to 13,000 cohort members to characterize rates of smartphone and consumer wearable device ownership and usage over time. Those people who report ownership of a device are then invited to make a one-time data donation to us that we grab and link back to what amount to 2 decades worth of survey data, biospecimens, and clinical data that have been collected on the cohort members. Right now, we are on track with this work to develop the first and largest open consumer wearable device data set in the history of research, which should be pretty cool and I think pretty exciting. So this is fun stuff. At the end of January, we wrapped up our participation in CDC's Healthy Behavior Data Challenge. The Behavioral Risk Factor Surveillance System at CDC is, for many states, their only source of public health surveillance data. And CDC acknowledged, this is a telephone-based recall survey that takes a long time to do, and a long time for people to answer these questions. Is there any way you can use sensor data to kind of augment what we're already capturing on people? So we took the BRFSS item, we sort of rewrote them for self-administration from being telephone administered. We spun up a mini version of BRFSS in REDCap, and we went out to Mechanical Turk. And we screened 600 people in the course of 4 hours who were like, yeah, I have a wearable, and yeah, I'll give you my data. We had them complete our adaptation of the RFSS, and then of those, we have a sample of about 300 people for whom we got 30 days retrospective Fitbit data. And we're in the process of linking that with their BRFSS responses. We have minute-level data on physical activity, sedentary behaviors, sleep, and in some cases where people are tracking this, full biometric data as well, really heart rate. Which is really exciting. So we had about a year's worth of support internally at RTI to deploy, what was a pretty fun pilot with the city of Durham and the police department. We just kind of casually referred to this as biometrics and policing. We use this device, the Empatica E4. We were primarily interested in looking at states of arousal and objectively quantifying and characterizing states of arousal and how they change over time in patrol officers in Durham. So we went out and we found 3 officers who were willing to participate in this pilot. We obtained over 600 hours of biometric data from these individuals, some of which was being sampled at a rate of 64 times per second. So it was a mountain of data. We took it. We also had event logs that we were able to match states of arousal with, what were they doing at the time, and then spatial data to say where were they when they had the greatest sort of response to what was going on around them. Really quick sort of novelty fun work that we've been playing around with as well is the use of drones to acquire and serve as a signal relay, but acquired biometric signals from wearers on the ground and then autonomously follow the people. So back on Labor Day weekend, I naturally volunteered myself to go into work and equip myself with a bunch of physiological sensors and run around while the drone chased me. We had the cool FLIR thing going as well, and we were able to kind of rig this thing just to kind of demonstrate the potential for streaming biometric data to a drone and either hang onto it there or pass it on somewhere else on a communications network. Why would anybody want to do this? Well, if you think for a minute about the increasing use of drone technologies or unmanned aerial vehicles in first response and sort of emergency response and protracted emergency response, think California wildfires, think no cell signal where they are, and then ensuing mudslides afterward. When drone operators fly into areas like this, unless they live in this place, they don't know what's what, and they lose these sort of geographic points of reference. So we've been working with DJI and another technical partner to develop an AR overlay intended for use on this sort of drone imagery. And then sort of taking it a step further, our principle and what we're starting to pilot now is the explicit integration of, in the setting of like this emergency services response, being able to have sort of the contextual landmarks and sort of the highlights of risk, but also being able to, at the individual level, stream physiological data back to incident commanders to kind of better monitor the responders, their health and wellness, their effectiveness in doing this. So, I don't know, he's here again. I don't know if this made any sense or was helpful or whatever, but if you have any questions, we may have time for one. But I appreciate the opportunity to be here and share this.
So we do have time for one question, but that sparked all kinds of cool ideas, I'm sure, amongst people. Anybody have a question?
Katie.
Have you swallowed any of the pills?
No, but I totally want to. You reach a point of sort of modifying your body where you don't maybe worry quite so much about what you're doing. And I'm an ardent supporter of self-experimentation and self-tracking. And I have generated my own. I mean, I got a Fitbit when they first came on the market. I generated a 4-year minute-level Fitbit data set that's out there and open for the world to see and do things with and kind of play with. And in the same way that I'm wearing this thing now, I do a lot of tracking of myself, mainly just for fun. Continuous spatial data on my phone for the last 4 years that we've been doing some really fun analysis and visualizations with. So as soon as I can get one of these swallowables, I'm all over it. As long as I don't have to like recover it or do any it's disposable, right? So those are my terms. But, yeah.
How many of the categories are medical devices that have to be regulated?
In that total count?
Well, no, more in like you were talking about wearables, implantables, hearables.
How many of those? Yes. Okay, so I'm a regulatory enthusiast and an IRB committee member at RTI. So I'm really into the regulatory and the sort of human subjects protections and the ethical kind of implications of all of this too. The grounds for how to characterize something as to whether it is a medical device or a consumer device revolve exclusively around the claims that are made in the marketing of that product. Watch a Fitbit commercial. Like, if you've ever seen one, they don't say anything, right? They're like, you run, and people are like, yeah, and that's it, right? But they're not like, you're going to lose weight, man. And then on the medical side, the really critical distinction is that a medical device defined as a product intended for use by a healthcare provider in the course of screening, diagnosis, or treatment of another human in the course of delivering healthcare. So if you can skirt like all of those and be like, you might want to use this and share it with your provider, that's not intended for use by a clinician, right? It's intended for use by the patient, but may just incidentally be shared with somebody who works in a hospital. So it's kind of fun and interesting to see what's happening here. FDA, under Scott Gottlieb, the new commissioner, has been doing a lot. They've launched this thing in the last 6 or 8 months called the Pre-Cert program. All of big tech is in this. The Pre-Cert program enables companies that are generating these kinds of things in this gray area of will it be regulated or not, to get into kind of an accelerated regulatory review and approval state. And the pre-certification implies that you do a lot of this front-end work and then show up with an app and are like, yeah, look, it doesn't, it's not going to kill anybody. And then they'll do it. The threshold is actually really low. So a lot of times the first gate for regulatory stuff is, and it's just like safety. Like, is this going to harm someone? And if people can demonstrate that, the wearable isn't going to explode, and burn people, disfigure them or whatever, or that it doesn't put people at increased risk, then the bar is really low. The Omron device, for example, screening, diagnosis, and treatment of hypertensive patients in hypertensive crisis, tolerances around measurement error that they need to demonstrate before they can really be approved. So that was long, sorry.
Thank you so much.
Thank you.